All right, so next we'll look at pulmonary embolism. An embolus is anything in the circulatory system that moves from its point of origin to a distant site and lodges there. It can obstruct blood flow either completely or partially in the area. The emboli can be fragments of blood clots in an artery or vein that breaks off and travels through the bloodstream, or a foreign body such as a bubble of air. In your pregnant woman, this can also mean amniotic fluid that travels through the systemic circulation and cause that blockage. A pulmonary embolism is really a blood clot that circulates through the venous system and into the right side of the heart and then lodges in the pulmonary artery. So, in your diabetics, for example, especially if surgery was done on the lower limb or even the pelvis, then blood clots can develop in those areas, break off, travel to the right side of the heart, lodges into the pulmonary artery. Additionally, during atrial fibrillation, a clot can actually develop in the right atrium and cause the same effect. Okay. Signs and symptoms of pulmonary embolism. It can include the following. 1, dyspnea, difficulty breathing, tachycardia, rapid heart rate, tachypnea, rapid breathing, varying degrees of hypoxia, and this can be as a result of the size of the embolus. Cyanosis also depends on the size. Acute chest pain and hemoptysis, which is coughing up of blood. All right, now we move on to hyperventilation. Hyperventilation is overbreathing to the point that the level of arterial carbon dioxide falls below normal. This may be an indicator of a life-threatening illness. For example, the body may be trying to compensate for acidosis, which is a buildup of excess acid in the blood or the body tissue. This can happen during diabetes, diabetic ketoacidosis, when the patient's blood glucose level is very high. It can even happen when there is salicylic acid poisoning, like that aspirin poisoning that we were talking about in the first presentation. So the body starts to overbreathe or to hyperventilate in order to blow off the excess carbon dioxide in a bid to reduce the acidity of the blood and body tissues. This may actually lead to alkalosis. And a lot of which is a buildup of excess base. So the body overcompensates and there's now a buildup of excess base in the body fluids. This can cause the symptoms of panic attacks such as anxiety, dizziness, numbness, tingling, or painful spasms of the hands and feet. Right. Environmental or industrial exposure. Pesticides, cleaning solutions, chemicals, chlorines, and other gases can be accidentally released at industrial sites and inhaled by employees. Normally, these places will have their protocols for decontamination. So by the time you come, then some sort of decontamination would have taken place. Carbon monoxide poisoning. Carbon monoxide is odorless, and highly poisonous. It is produced by fuel burning household appliances and is present in smoke. In areas where you have fireplaces, this usually happens when there's incomplete combustion. And the danger with this is that carbon monoxide poisoning is very it's very hard for you to notice. Sometimes it's persons that are sleeping actually exhibit symptoms of carbon monoxide poisoning. Also, carbon monoxide has a very high affinity for hemoglobin, and so they tend to bind even more strongly to hemoglobin than the oxygen would. People who have carbon monoxide poisoning, they often complain of flu-like symptoms and shortness of breath or difficulty breathing. If you respond to a scene and you see multiple persons experiencing these flu-like symptoms, do not put yourself at risk. Always think of the possibility of carbon monoxide poisoning. High flow oxygen by non-rebreathing mask is the best treatment for the conscious patient. Scene safety. Use standard precautions and well, now we're actually doing our patient assessment. So for the scene size up, we use standard precautions and use PPEs. Consider the possibility of an infectious disease or a toxic substance. And as I said before, if there are multiple casualties with dyspnea, consider the possibility of an airborne hazardous material released. If the mechanism of injury or the nature of illness is in question, then ask why 119 was activated. You can also question the family members, the patient, and bystanders in order to determine the nature of illness. During the primary assessment, you identify and treat immediate life threats. Form a general impression. Note the age and the position of the patient. Is the patient in the tripod position? That may indicate that there is some sort of respiratory distress. Use the AVPU scale to check for responsiveness. If the patient is responsive, then you ask about his or her chief complaint. All right, so you're going to start working on the ABCs, airway and breathing. Make sure that the airway is patent and adequate. So it may mean that you have to reposition the neck. Assess rate, rhythm, and quality. Remember, rate, how you do it, you observe the patient's complete chest rise and fall for 30 seconds and then multiply that by 2 and you'll get the respiratory rate. The rhythm, how consistent is chest rise and fall? And of course, the quality. Am I seeing equal chest rise and fall? Am I hearing the abnormal breath sounds like wheezing, crackles, gurgling, snoring? Ask the following question. Ask yourself, is air going in? Does the chest rise and fall with each breath? And equally so? And is the rate adequate for the victim's age? Gonna now look at assessing the breath sounds. Now we check the breath sounds on both the right and left sides of the chest. Abnormal breath sounds include wheezing, rales, rhonchi, and stridor. And again, at the end of the presentation, we will listen to some of these. Circulation, we assess pulse rate, 30 to 60 beats per minute. Rhythm, is it consistent? Regular intervals. The quality, is it weak, strong, steady, bounding? Evaluate for shock and bleeding. And you assess perfusion by evaluating the skin color, temperature, and condition. Transport decision. Now, if condition is unstable and there is a possible life threat, you're going to address that life threat and then proceed with rapid transport. For history taking, investigate the chief complaint, find out what the patient has done for the breathing problem, and of course, carry out your sample history. If there is chest pain, especially, do the OPQRST assessment, onset, provocation or palliation, quality, radiation / region, or severity. There is an additional assessment called the PASTE. It's specific for patients with dyspnea. The P is for progression, and it's similar really to the O in the OPQRST. You want to know if the problem started suddenly, the onset, or did it as it worsened over time. A is for associated chest pain. With chest pain in the presence of dyspnea can be a significant symptom of a cardiac problem. Sputum, for S for sputum, has the patient been coughing up sputum, which is mucus-like sputum, really could indicate respiratory infection, while pink frothy sputum is indicative of fluid in the lung, and a problem like pulmonary embolism may not have any sputum at all present. T is for talking tiredness. This is really an indicator of how much distress the patient is in. So we're going to ask the patient to repeat a sentence and see really how many words he or she can speak without taking a breath. So the patient probably can speak in full sentences or perhaps speak in 2 or 3 word sentences. E is for exercise tolerance. So what we would do in this case is to ask the patient a question about what he or she was able to do before the problem started. Like if they could walk across the room, and if they answered yes, and ask them, do you think you can do it now? Then if the answer is no, then it's an indicator that your patient is in distress. Exercise tolerance will decrease as breathing problem and hypoxia increases. In your secondary assessment, it's a more in-depth assessment of the body system. You proceed only after addressing life threats. And of course, you're going to be using your monitoring devices if you have them. Monitoring devices would be like your pulse oximeter, your blood pressure machine, and if you have any other devices like even your blood sugar machine. Look out for patients, doing a secondary assessment in patients with COPD, you look out for signs of COPD like these patients are usually older than 50 years old. They have a history of lung problem. They are almost always long-term active or former cigarette smokers. They complain of tightness in the chest and constant fatigue. The chest may have a bar-like appearance because they have long expiration phases. So normally this, in order to get out the trapped air out of the alveoli. They often use accessory muscles to breathe. They exhibit abnormal breath sounds, wheezing. They often exhale through pursed lips. And they have digital clubbing, which is really that abnormal enlargement of the ends of the fingers. Right? So for reassessment, we repeat the primary assessment, assess for changes in condition. The interventions that we may provide would be like providing oxygen via non-rebreathing mask at 15 liters per minute, providing positive pressure ventilation using a bag valve mask device, a pocket mask, or flow-restricted oxygen-powered device, using airway management techniques such as oropharyngeal airway, nasopharyngeal airway, suctioning, or airway positioning. We can also provide non-invasive ventilator support, CPAP, positioning the patient in the high Fowler position or the position of choice, assisting the patient with respiratory medications. We assess for stable patients, we assess every 15 minutes, and for unstable every 5 minutes. We need to communicate all relevant information to the staff at the receiving hospital. Right. So when a patient is in respiratory distress, we need to administer supplemental oxygen immediately. We administer ventilator support if the patient's mental status is declining, if they are in moderate to severe respiratory distress, or if the depth of respiration is inadequate. You always monitor the patient's respiratory status and provide emotional support. Of course, the patient may have a metered-dose inhaler or a small volume nebulizer depending on the disease state, and you consult medical control and make sure that the medication is indicated. Ensure that there are no contraindications to the patient's condition when you're administering a medication. Most respiratory inhalation medications are used to relax the smooth muscles that surround the air passages in the lung, so it leads to dilation of these airways. But as a side effect, it may cause increased pulse rate, nervousness, and muscle tremors. The medication from a metered-dose inhaler is delivered through the respiratory tract and into the lungs. There is a number of skill drills that you will be able to do in order to know how to properly help a patient with these devices. All right. Well, we're going to now be looking at the treatment of specific conditions. If there is upper or lower airway infection, then we need to administer humidified oxygen if available. Do not attempt to suction the airway or place an oropharyngeal airway in patients with suspected epiglottitis. Position comfortably and transport promptly or rapidly. For acute pulmonary edema, provide 100% oxygen, suction if necessary, position comfortably, provide CPAP if indicated and allowed by protocol, and transport promptly. For chronic obstructive pulmonary disease, COPD, then you assist with the prescribed inhaler and you watch out for side effects. Because remember, sometimes you have to make sure, you have to ensure that patient tells you if they've used doses before. Position comfortably, transport promptly. Asthma, you have to be prepared to suction the patient, assist asthma patient with their prescribed inhaler if that's present, provide aggressive airway management, oxygen, and prompt transport. Hay fever, this is unlikely to need emergency treatment. Anaphylaxis, then in this situation, you're going to remove the offending agent. Suppose it was a bee sting, then you wouldn't use a tweezer to take out the sting if it's still there, because by doing so, you'd essentially be squeezing more of the venom into the patient, underneath the patient's skin. So you get something like, those sharp edge cards like a credit card in order to remove the stinger. You maintain the airway, transport rapidly, and administer epinephrine. spontaneous pneumothorax. Or you provide supplemental oxygen, transport promptly, monitor carefully. Pleural effusion, fluid removal has to be done in the hospital. So we just provide oxygen, transport promptly. Obstruction of airway. For a partial obstruction, you provide supplemental oxygen and transport. For a complete obstruction. You have to clear the obstruction, administer oxygen, then rapidly transport to the emergency department. Pulmonary embolism. You administer supplemental oxygen, position comfortably. If hemoptysis is present, then you clear the airways. You may have to clear the airways repeatedly, and then you transport promptly. Hyperventilation. Complete your primary assessment and gather the history. Do not let the patient breathe into a paper bag. This is something that is a common thing, to let somebody breathe into a paper bag. But if the patient is trying to get rid of carbon dioxide and you allow them to breathe in the expired air, then you're putting back the carbon dioxide in the blood. Reassure the patient and provide supplemental oxygen and transport promptly. Environmental and industrial exposure. Ensure the patients are decontaminated, treat with oxygen, adjuncts, and suction based on the presentation. Foreign body aspiration. Clear the airways, provide oxygen and transport. For tracheostomy dysfunction, you position the patient comfortably, suction to clear the obstruction, and provide oxygen. For asthma, in certain populations like your children, you may have to provide blow-by oxygen because they tend to be afraid of the mask over their face. So you could hold the oxygen for them and allow it to just blow in the face. The caregiver or family members could also hold it as well. And of course, you use the meter dose inhaler. Cystic fibrosis. All right, so this is a genetic disorder that affects the lungs and digestive system. This predisposes children to repeated lung infection. In this sort of disease, the mucus, the body secretions are normally thick. So of course, if this thick mucus goes in the lung, it can trap bacteria, white blood cells, and cause an infection. Symptoms range from sinus congestion to wheezing and asthma-like complaints. You would suction and oxygenate as needed. All right, we are at our review section.